Golden Peacock Oration, which will be delivered by Dr. Samuel Lamb. Could I request Dr. Lakshmi Dhami and Dr. Ramchandran sir to please come and chair the session?
Good afternoon, everybody. After a hefty lunch, I'm sure you are all waiting for the next session to start. And it's my honor to introduce Dr. Samuel Lamb, Sam, as he prefers to be called. And he is a facial and hair restoration surgeon practicing in Dallas, Texas, in USA for many years. Currently the Vice President of American Board of Hair Restoration Surgery. He is a Senior Fellow of International Society of Hair Restoration Surgery. He is also an author of 10 textbooks, of which 6 are on hair transplantation alone. He is the director of St. Louis Hair Transplant 360 workshop, and you have the brochure right in front of you. Those who want to attend can definitely contact him. I present Dr. Samuel Lamb, and he's going to give a Golden Peacock Oration on eyebrow restoration.
Thank you so much. This is a painting I did of myself, so I decided to use that instead of a photograph. So I'm going to talk about eyebrow hair transplant. It is a very advanced topic, and it's one of those things that I have a lot of beginners come to me and say, I want to start learning hair transplant. Can I start doing eyebrows? And I say, this is the last thing you should learn. It's the last thing you should do because it's so easy to make mistakes and make it look bad. And you have to have the best staff to help you, otherwise your results will look bad. As you know, there's been a trend toward thicker eyebrows, and I think that's why you see an increased demand in all your celebrities wanting thicker eyebrows. And so there are many things. Function is one of them. Sweat coming down, it has a protection. There are certain cultures in which shaving the eyebrows may be a certain ritual. As you know, that there can be a humanness lost when there is a loss of the eyebrows. And it also talks about youthfulness and gender as well. So the indications would be in the past overplucking where the hairs don't grow back. You want to cover a bad tattoo that looks unnatural. Congenital reasons that are just born that way, traumatic hair loss, and of course hypothyroidism. I heard just recently here that India does not have a high FFA prevalence. We do in the United States. We need to really make sure that we make that differential diagnosis and have a low threshold toward biopsying. So the restoration options, you have to give your patients options. Nowadays, instead of the tattoos that look very unnatural, they have microblading techniques that could be a good alternative for them. And so when you do a transplant, there's so many things you have to keep in mind in terms of artistry, gender, ethnicity, facial, taste, etc. And so when you look at an eyebrow transplant, typically if you are skilled, it takes a few hours in the morning. By early afternoon, you're done. Grafts per side are between 400 to 600. And if you're starting out, it could be a lower count. We'll talk about that. And then obviously a few days of recovery time where could be swelling around the eyes, and then a few months to regrow. The design principle here, from a microscopic perspective, there's this fanning approach that on the head that becomes this fishtail everyone knows about, and then it goes over to the side where it tapers off. You could look at the medial portion being at the lateral canthus, the peak for females being at the lateral limbus, arching up from the point of the ala, and then the point of the lateral terminus being through the lateral canthus, starting again from that nasal ala. But all those principles aside, what has worked for me in my practice is I have my patients design it themselves first. And during the consultation, because otherwise you're sitting there drawing it for 20 minutes and then they say, that's not what I want. Let them design it first. They'll save you time. And then if it looks really off, you can give them input of what maybe looks better. And you want to do that during your consultation. They can even draw it in before they get to your office. So that way it saves you some time. And then I just reinforce that area with a permanent marker. So considerations, you remember that donor dominance? I had a talk earlier this morning about that. And the concept behind that is that, the hairs potentially grow as fast and they may never slow down. They may act like the scalp, and you cannot base your results on recipient dominance. So donor harvesting, there's linear strip harvesting or FUE, we'll talk about both of those. For me, I don't like non-shaved approaches, so I look at FUE as someone with a short hairstyle that you're worried about a linear scar. If they've not got the suitable hair in the exact region, then I will be doing FUE. Women and long hairs, I just think FUT or linear strip is best. These are the tools that I use for FUE. And then we're going to talk about how to do FUE donor anesthesia. So for me, I start with just putting a few punctate injections along the occipital nerve. It's very hard to identify exactly where the nerve is, but I just put a few drops. That allows me to put the FUE donor tumescence in. And I'm going to have this on YouTube, but you're welcome to take a photograph of this formulation. And this, obviously, you don't need 250 milliliters of saline for the donor if you're just doing an eyebrow. But it is good because I spread out that area so that there's less risk of seeing dots on the back when I'm doing a eyebrow transplant. So I do harvest from a wide area. And you can just do some calculations, for example, just reducing the amount. And I really think this dilute bupivacaine holds long enough for both standard FUE as well as FUE for eyebrow transplantation. So from these initial punctate points, I use a 25 gauge needle and I go straight through that area that's already been anesthetized with standard lidocaine dosing, and I just bleb it up. So I just go along this occipital nerve and continue to expand it. Then I go down, I go across, and then laterally. And so this is a schematic. I put those little entry points, and then I begin the FUE donor tumescence. I really believe this is the key. It is a field block. It allows me to get the best anesthesia, and I just progress around those occipital nerves, expanding upwards and eventually outwards from there. So I would encourage you, if you do harvest for eyebrow transplants, don't harvest from mini strips, don't harvest from a small area, don't do a little window shave, harvest from a wide area, because if the whole point is they want to wear their hair short or maybe eventually shave their head, you want to minimize the risk of having exposed dots. So a wide harvest zone is important. To do linear strip or FUT, I believe that the ring block is the key, and then tumescence just to minimize transection during the harvesting. So you can do these, they're under minimal sedation. I just put little drops again with these 30 or 32 gauge needle of just 1% lidocaine to 100,000. I like to use 4% septocaine or articaine to join these areas. It provides profound anesthesia, and you don't need very much dose for that. And the tumescence preparation is identical to what you saw, except I don't think you need the bupivacaine, dilute bupivacaine, because all I do is I go back and add a high concentration of bupivacaine along the linear incision at the end of the procedure. So it's the exact same thing you saw. All I do is I just take out the dilute bupivacaine component. So tumescence, I use a 21 gauge instead of a 25 gauge, and just sort of in that subcutaneous plane, blow it up as much as I can. Then I come back along my proposed incision and I go almost intradermal or very superficial subcutaneous and further tumesce that. That way, where my harvest is, I have that much less chance of transection during a linear harvest. So we'll next talk about recipient site anesthesia and creation. You need to know the anatomy. So the way that the nerves are distributed is you've got the supraorbital bundle medially, and then you've got the lacrimal gland laterally. But to really knock out your lacrimal gland is not so easy. So to me, it's a regional block, meaning, in other words, I'm hitting a nerve, and then a direct block, which means I'm hitting along the pattern. So what I do is I inject straight into the supraorbital nerve. It blocks out the medial half, and then I go across the actual expanse of the eyebrows, going within it and going outside of it so that I don't smear my lines. And as I said before, I really like this 4%, articaine is the generic name. I use dental carpules, and then a trick here is I push up the dental carpule until that little cap is almost out, and then I take it out. That way you don't have the air pocket you can't draw against it. And I just draw up 1 milliliter syringes of this, 4% to 100,000. The reason I like it, you don't need very much anesthetic load, and it provides profound anesthesia over about 3 or 4 hours, and it's easy to touch up if you need to. So this is just an example. I think everyone knows how to do a supraorbital block. I don't need to go into that. And then just showing you that I inject outside the line, inside the line, until they're fully anesthetized in that area going along. During the procedure, you want to provide some eye coverage or protection so they don't have so much illumination in their eyes. I just prefer a Curlex bandage wrapped around. And also, if I'm doing a linear harvest on the back, it sort of helps soak up any of the heme on the back side. Or you could do a folded face mask. Of course, right now with the coronavirus, you probably don't want to waste one of these for this, but you put that with some padding underneath, like some 4x4 gauze folded. It's a way to sort of mitigate some oozing into the eye area and also provide some illumination coverage. So, how have I evolved my technique? This is the core of the talk right now. So I started using perpendicular sites, also known as coronal, but as you know, that's a misnomer in this situation. Perpendicular sites, I migrated, and I'll tell you why in a moment, to parallel sites that were 2 hairs in the center and 1 hair in the perimeter, which I got very good results on. And now, for the most part, I use parallel sites using almost exclusively 1 hair grafts with some exceptions. So why don't I like perpendicular sites? Of course, there is this idea that perpendicular sites or lateral slits provide you an ability to not let the grafts go up, because if you have high tilted grafts, they don't look natural. So let's talk about that. So if you think about if the perpendicular sites are placed, this is a side cross section. Let's just picture this being the top of the head. If you look at a side cross section, and you can make them like this, and you don't get the sites joining one another. However, let's look at this. This is a frontal view. So I've changed the view. Frontal cross section. If I'm making parallel sites in the eyebrow, and they're very low angled, they all compete underneath the skin surface. And so when I make perpendicular sites, I can't get them tight enough. Does that make sense? This is a very critical point. So of course, if you do parallel sites, there are some risk, and I'm going to talk to you about how to avoid them. But for me, I can't dense pack my eyebrows sufficiently with perpendicular sites, if that makes logical sense, because the sites are too low angled. The other reason is simply I can see my design, and my staff can see the design because they can see the flow with parallel sites. So this is another reason I advocate it. And along those lines is a similar topic, is that I don't join my sites together as much because they don't compete for the same space, because that angle is so absolutely low. And I'll talk to you in a minute about how to achieve those low angles. So this is an example when I was making perpendicular sites. I can't see my pattern. My staff can't see which way they flow, and they're not that dense. Now that I'm doing parallel sites, you can see the angulations and direction, and you can see I can make it much denser. Of course, always start, whether it's FUE or linear strip harvesting, make sure you test that graft length so that you don't go and make all these sites and nothing fits. So always test a couple sites first. So what is the problem with parallel sites? Of course, this is the reason a lot of you say don't do it, because you can't get them low enough, right? It's going to look weird. And I would agree with you. If you are not comfortable making your sites flush with the skin, your angles will look crazy, okay? So yes, they can still ride up a bit, but I've found that if you make your sites low enough, you're not going to have the situation where the hairs stick out in a weird way. So how do I do it? Triple bend. Boy, that's confusing. What the heck are you talking about? When I try to teach this in St. Louis, people look at me with a glazed over look. So for beginners, I stopped teaching this. But I want to show you in the next 2 to 3 slides what I mean by a triple bend, okay? The next one will be a little clearer. So look at this. A double bend allows me one bend like this, and allows me the graft length. It defines the graft length, right? If I'm bending a needle. But the third bend, which you're seeing on the lower image, allows me not to have to torque my hand all the way down, so that I can keep my hand up and not have to try to angle it like this to keep the low angle. So that's why I like that triple bend. Here's another view, as you can see that how flat that site is being made, but how high my hand angle is. I don't have to torque it like this, okay? And then if you bend it, this is another esoteric, it is a very advanced comment for beginners are going to be even more thoroughly confused. You can bend it one way or the other. Why is that bend that I'm showing on the left better? Because when I'm looking at this, the bend is not blocking my eyesight, the line of sight as I look at it. Does that make sense? I know this is a bit esoteric, but hopefully you get it. And I'm more than happy to answer the question after the talk. This is just showing you how I make these sites. This is a video, hopefully that will play. Oh, did not play. Did it play? No, did not play. How do I go back? I can go back like this. How do I go back? How do I go back on this? Okay. Oh, there it is. Okay, let me see. Can I just click on that to hit play? Okay, well. Oh, there it is. It's playing. Good. Okay, well, I'm only showing the inside sites. It's the same thing. But you see how I stop? There's a little where I just get into the skin and then I torque down and go in. So that little technique is important. So that way you don't skive across. It's very easy to slip and make your site too large, especially when you're going such a low angle. So I start from, oh, let me go back one. I apologize. How do I go back again? This thing is, here we go. Okay, perimeter tips. So I do that first. I draw the perimeter around first, because that way I don't lose my line. I stagger the line like a hairline. You don't want to make a straight one. And agree beforehand with the patient. Do you want it on this line or do you want it inside the line? Because that's a little subtlety that can be important. Do both sides, check symmetry, check your numbers, make sure you're symmetric. The way you check it is take your magnifiers off and look, okay? Then, okay, I guess I showed this already, but it's good to see it again. This is just showing you how slow I am in making those, and I make that touch, turn down, slide in, flat. So I think that's important. So from the body, I start from the head and go to the tail. Slight toeing in before you go flat, I talked about that, and rotating the head is important. I'll show you what that means in a minute. And always check for symmetry without loops so you can see the big picture. So rotating the head is as you're progressing to the tail to keep flat, I progressively turn the head so that I don't have to be cocked like this with my body position. I have moved, this is the biggest game changer for me in the last year and a half, is moving from 2.5 to 4.5 loops. This is the same loops that I use for FUE harvesting. My God, I can see better. Maybe because I'm old. I don't know, but I see so much better. Now I can dense pack. That's what has converted me from needing 2 hair grafts in the center to 1 hair grafts, because I'm now using 4.5x loops with a better focal distance for that. So my workhorse is a 22 gauge needle. And I move from 21 gauge. Of course, if your staff cannot place into it or if you cannot make the design appropriately, use the appropriate sites that your staff needs. So this is basically moving from doing a one, when I was doing 2.5 loops, I was using a perimeter of 1s and then 2s inside, and now I'm using mainly all 1s, but not in every case. And I moved from a much higher graft, almost double the graft count now, but I'm not using 2 hair grafts, and I still got very natural results with 2 hairs. I just think that if I can dense pack 1, I'm going to get even better results, and I think I've seen that now. So I use platelet-rich plasma and 100 milligrams of the A-cell, no financial affiliations with any companies. I injected it right before graft placement. So these are the biocellular techniques that I use. I truly believe these things, from liposomal ATP hypothermosol, all these things are huge for me to get better results. Graft placement is so understated here. If you are the most advanced surgeon and your staff cannot trim these grafts properly, if they're doing a linear strip harvesting, follow the hair curl, follow that curl as it goes across. Not traumatize the grafts during insertion or double stack them by accident, you're not going to get good results. Absolutely just not going to get results. So you have to be not only the most advanced surgeon doing this, but you have to have the most advanced staff and the best staff doing this. And unlike how I make my sites from head to tail, they make it from tail to head so that they don't compete on their sites as they're placing. So graft placement really is so tricky. It is so important to do it well. So check, double check, check, double check, check. Let the patient see it. Always have spare grafts, because the patients will always complain, oh, I think this is here, I think I could do. And if you spend that extra hour renegotiating some of those details, the patients will be much happier than just finishing the procedure and being done with it. Microblading is now an alternative, and there are pros and cons. If you've got a great artist who can do this work, patients may prefer this. They may not want some of the negatives of an eyebrow transplant. So what are they? This is a simple schematic here. So the difference here is that microblading is temporary for the most part. It's gone, whereas eyebrow hair transplants are permanent. They look like eyebrow hairs because they're eyebrow hairs. They're three-dimensional. They're hairs. But they both require artistry. So that is a difference. But the problem with this is if you do not get recipient dominance, you're going to have to trim them every few days. And I'm going to talk about how to do that more easily. So there's potentially even more maintenance with eyebrow transplants. And I tell all my patients that, especially my male patients. And you need to really think about these pros and cons and give your patients proper counsel as they're thinking about having it done. So I love these thinning shears. They look much better. They layer. Like if you have an advanced person that is cutting your hair, they may use thinning shears. I give my patients these thinning shears after an eyebrow transplant. I don't just say, go trim your eyebrows. I show them how this. I have videos on YouTube that tell them this is how you trim your eyebrows so that they don't have confusion about it. If they have a question, my staff knows how to show them if I don't. So the challenge is acute angles. My God, these have to be flat. This is not even 10 or 20 degrees. These are super flat. You know why? Because when you make it flat, they're still 10 to 20 degrees. You make it 10 to 20 degrees, they're 40 degrees. I don't care if you make perpendicular or parallel sides. You have to be an expert in making consistently low angles, flat to the surface. Small sites, fragile grafts. The hair curl has to be perfect. If your hair curls, if you know what that means, right? The hairs exit from the epidermis at a certain curl. If you do hair curls on your scalp slightly off, maybe it doesn't look that bad, but you really is still unacceptable. When your hair curl is off on your eyebrow, it's totally screwed up. So this is so important. White hairs add another level of complexity that's even worse than if you're doing white hairs on the scalp. Coarse hairs, do they look natural? Ethnic hairs, African hairs. So some aftercare details that you may think about. Just like for my scalp transplants, etc., I don't wash the hair for 24 hours. I use a gentle shampoo. I tell them not to rub against the direction of the transplanted hairs. Always dab, don't wipe. And again, no financial affiliation, but I love liposomal ATP. I think it's my best friend if you have it available in this country. I don't know. I spray it every 1 to 2 hours. I tell them to spray it every 1 to 2 hours. And then normal hair washing after a week. If it starts to get scabby, I like to, start putting a radioplex or an emollient onto their scabs. That way they don't scab too much, and definitely, obviously, don't pick at the scabs. One pearl is I found that with linear strip harvesting to get better donor incisions, I like to leave my sutures in for a minimum of 14 days. So I prefer 14, 15. If they can't take it out for 21 days, I think the results are even better. If you start taking it out, I used to take it out day 10, first started day 7 to day 10. I'm getting much better outcomes with much longer times of keeping them in. This is a technique of just if your hairs are not flat enough, you can help guide them after the first week, from first 2 to 3 weeks with an ACE wrap, just gently holding it down, and as the grafts start to come in at 3 to 4 months, I sometimes have them do this as well. I don't really now need this because I think my sites are pretty good, but this is a trick that may be out there. So this is traction loss and eyebrow loss. Of course, what you worry about is this CCCA, FFA? Is this something where you're missing? If there's a question, please just biopsy it. It's much safer. And you can see there's a lady from out of town. I don't have a consistent after photograph, but she's elated because when you have eyebrows, it gives humanity back, gives life and femininity and youth. And again, a combination of eyebrows and hairline. This is an over-tattooed look that just doesn't look natural, and now she looks natural. This is an over-plucked and tattoo combination that looks bizarre, and now she looks less like, I hate to say, Groucho Marx, if people know that reference. Coarse hairs, over-plucked hairs, very hard to achieve natural results. This is definitely a case where you got to be careful looking at 2 hair grafts. Using FUE for both a combination eyebrow and beard transplant. This is a cancer reconstruction, a lady that actually cried during a testimonial, and she didn't want thick eyebrows. This was done many years ago when that was not in vogue. She just didn't like the fact that she felt ostracized by the world, and she wanted to look normal. And so just putting a few grafts there made a big difference. And these are just disasters. People came to me, this is actually the before, is already after she plucked out all the mess. It was a local surgeon putting grafts using a robotic technique, thinking, okay, you know, just because I've got it, I can do it. It's not the case. This is so hard. And so her angles are all messed up, so this is a reconstruction. And pretty good survival after one transplant through thick scar tissue in this area. A reconstructive procedure for a gentleman that also failed eyebrow transplant by someone that doesn't even do hair. And the grafts were all over the place. They looked horrible, had to take all of those out. So if you get in a situation where the grafts look bad, take them out. Don't try to fight against them. Get rid of them. Electrolysis, plucking, laser, whatever it is, get rid of the grafts and start from the scratch. Traumatic case, bad tattoo looks off. Need to fix that by doing a transplant. And the take is very good in scar if done, I think, with some of these good technique and regenerative medicines. This is a case report that I'll be presenting in the forum. This is a lady that had a bad tattoo, and then she tried to do her own self-inflicted chemical treatment, and it started getting a keloid. She presented to me with these frank keloids. So I did a combination of 5-fluorouracil and dilute triamcinolone until I got it flat. Took me several rounds to get there. I did the case with African American hair. Sometimes those hairs are very splayed. It's very hard to pack in one hair, so I used 2 hairs. I did a FUT, or linear strip harvesting, and the reason I felt comfortable is 2 reasons. Number one is that the area that she has earrings on, so I know that she didn't keloid. Number 2 is that this is self-inflicted. It sits outside of a normal keloid area. Keloids typically occur at the perimeter of the forehead, going back to the occiput, and from the lateral face out. I do a ton of keloid excisions, probably 1 a week, major, devastating occipital, nuchal keloids I remove. So I have a very good understanding of keloids. So I will tell you that I knew this was atypical, so I treated it atypically. Well, at 1 day she was happy, you can see. 6 months, not so happy. Why? Overall, pretty good result, but there's these areas that regrew that really made me upset. All of a sudden, some of the keloids came back. So I put her through 3 rounds of this to get it down, and now she was like, I'm still not happy with this. What can you do? Because I still see these little holes. So then I thought to myself, okay, what should I do now? Should I go and just put more grafts in? I thought, okay, we could, but then what will happen is she would have potentially keloids come back again. So I decided I'm going to cut it out. And I've been using 7-O-Vicryl, polygalactin or something, I don't know the generic, Vicryl by Ethicon. Great thing for keloids. It doesn't sound like it makes sense that you want a non-absorbable, but for fine areas I use it. For large areas I'll use like a 3-O-proline, polypropylene. But in these areas, I leave it in there. And she healed well. She was ecstatic with the results. There's still a small gap, but she's just really happy. So the lesson I learned in this case report is I should have just cut it out. I should have cut out the abnormal keloid tissue, done the transplantation. I believe that I would have gotten a better result and not had to go and do more injections afterwards, et cetera. So before and after. This is the series before, after surgery, after final surgical excision. And so, Dhanyavad, shukriya. And I would say, think like an artist. This is fun. The reason I have a passion for this world of hair restoration is that it is design. It is beauty. It is design. And you don't know what you can do until you start. 2 months ago, I started doing portrait. You saw that first one, that was of me. This is my little child, little baby. And I just started going, oh man, I could actually draw. I can actually paint. I never knew that. Until you start to challenge yourself, you don't know what you can do. I invite you to Panama. I invite you to join the American Board of Hair Restoration Surgery. And I invite you to come to St. Louis for the workshop, July 24th through 25th. Thank you very much. Do I take questions or I start the next session? We probably should start the next. Probably should start the next session, right? Because we're on time. Yeah. Yeah, I probably should, we're on time to start the next session. Moderator, no?
It's an oration. It's an oration, so we have to just give you the
Oh, okay, sorry.
So, yeah, thank you so much, Dr. Sam. It was a pleasure listening to you, and you threw a lot of new insights into the artistry of eyebrow transplants, and I think it's a reckoner for all the people who are here. It's not something that's to be taken very lightly, and it's one of the most tedious, and it probably reflects the beautiful work of art that you're doing. Thank you once again for this wonderful presentation.
Dr. Satur, for the chairpersons. Yeah. Dr. Venkat, sir, could you just, for the momentous, for the chairperson, sir.
Yeah, let me use this.
Nano, sir.
Is there a... Oh,
Nami,
first
sir.
talk, first talk. On time here, I'm going to be moderating the next section. It is, the topic is on hair loss, patient assessment and management. It's part 2. And I welcome up Dr. Kapil Dua, my friend here, to talk about the ISHRS session. Kapil.
Yeah, we're going to start the next session now. The topic is Patient Assessment and Management Part 2. This will be started by, moderated by Dr. Lam.
So, good afternoon, everybody. So, this is a session on hair loss, but I wanted to introduce the association, which is the largest association of the world, International Society of Hair Restoration Surgery. So, I would like to thank the organizers, Dr. Satur, for giving this prime time to us when all the people are present. So I'm currently representing the ISHRS as the treasurer, and I'm the ambassador of ISHRS for this lecture, although everybody knows that I've been in HAIRCON ever since it started. Can we have it on? It's working. Can we have the second session? I think the next person, Dr. Sukhbir, is there with the session. So I think I can just check it up and then come back again. Sorry for the interruption.
Yeah, good afternoon, everyone. Thank the organizer, Dr. Satur, sir, for the permission. So I'm going to start on a very controversial topic, PRP. We have all seen the morning session that there's a lot of evidence being produced for PRP and against PRP, but finally whether it works or no, it's still a very controversial. Obviously, nobody says that you cannot use PRP. It's a very good adjunct which we can use. And I think it's being utilized not only as a combination therapy with minoxidil and finasteride, it's being also used as an adjunct to hair transplant. Especially, we have a lot of literature now which supports that it is a very good plasma holding solution. It not only improves the anagen phase, but also the effluvium stage is decreased. So let's see what types of pattern hair loss already been discussed. Just quickly go over that. So basically, there's a male androgenic alopecia, which usually starts from the frontal part, the hairline receding part, and the female pattern hair loss, which typically starts in the parting area and the vertex area, and very infrequently involves the hairline. And there are some special cases like alopecia areata. So this is a Ludwig's classification, which was given 3 grades, which have been described for female hair pattern hair loss. And then we have the Hamilton-Norwood classification, which has been defined for the male pattern hair loss. So what exactly is PRP? Is just a platelet concentrated in a very, very small volume. As we all know, it contains a lot of growth factors and cytokines, which definitely play a role in some form or the other. Obviously, a lot of research is being still going on, how much it's helpful in that. So just to name a few, it's platelet-derived growth factor, TGF-beta-1, vascular endothelial growth factor, fibroblast growth factor. So it helps in cell addition and acts like a matrix. So a lot of cytokines do play a role, like PTGF does play a very important role. It maintains and enhances the anagen phase, thereby enhancing the hair stimulation. We have the vascular endothelial growth factor and platelet-derived growth factor, and also the beta FGF. So we all know about the hair follicle interactions being discussed, so I'll not go into that. So let's go into the controversies and what is underlying the various parameters which do play a role in defining whether PRP works or not works, because some people say it works, some people say it don't work. So obviously there has to be some guidelines or parameters for that. So which is the best anticoagulant? This is still a very, very controversial, but a lot of papers have been published for that now. We all know that which is the best anticoagulant which can be used for preparation of the PRP and really works well. Then the relative centrifugal force, the centrifugation speed basically, which you do, whether you do the double spin, you do the single spin. Most of the people and studies have revealed that double spin definitely has a much better influence and role as compared to the single spin, but still there are numerous studies which also eliminate that single spin also gives a very good result. Then the temperature and time for spin. Then a lot of studies have suggested earlier that refrigerated techniques are utilized, but it has been time and again been documented very well that even a normal room temperature and appropriate time of spin is enough to produce a good result. You normally do not require refrigerated machine for that. Last but not the least, whether activity is required or not. Again, very controversial. Personally, I have my own reason for that. I'll be elaborating on that. So this was the comparative analysis which we had done and published. It's a detailed article, anybody can read it. So we did a comparative analysis. We did both a quantitative and qualitative analysis of 3 different reagents, that is ACDA, sodium chloride, and EDTA, and compared which was better to actually produce PRP. So we were of the conclusion that ACDA works the best because the percentage increase in the platelet concentration is the most important factor which actually determines whether your PRP will work or not. So we concluded that. We have a study and it's available online, you can read about it. Then coming on to other studies which have shown that yes, PRP does work or doesn't work, let's see. So this is a study of the efficacy of platelet-rich plasma in the treatment of androgenic alopecia in males. This was published in IGDVL 2017. The conclusion of the study was, on the basis of the trichosan evaluation, the percentage increase in hair diameter was 39.8 plus 17.2. Percentage increase in hair density was 39.7 plus 16.5. 28 patients, that is 93% of the patients reported complete cessation of hair fall as early as 2nd month of the treatment. That means it definitely has a role. So obviously it's a combination treatment which works, but definitely is helping in some way or the other. This was an interesting study which Dr. Venkat had revealed yesterday. There was a comparative study which was done on the efficacy of platelet-rich plasma as compared to 10% minoxidil and microneedling in patients of androgenic alopecia. This was published in World Journal of Pharmaceutical Medical Research. So the basis was to evaluate the efficacy of PRP versus topical 10% minoxidil and microneedling in treatment of androgenic alopecia, to study the safety profile of these modalities in treatment. Thirdly, to assess the patient satisfaction score in the above 3 modalities. I was very surprised to see the results, which I'll be sharing you. So in the study, the mean hair density in the PRP group of the first and last visit was 100.9 and 121.8. This is in comparison to the minoxidil alone group, which was 98.4 and 106.4. That means PRP is giving much better results or promising results as compared to minoxidil alone if we really just want to compare. Microneedling again gave about 104.2 and 114.9. So they did a statistical analysis and they saw that patients of PRP showed statistically significant, that is P less than 0.001. Anybody who does research work knows that statistical analysis P less than 0.001 is very, very significant. So it shows the increase in the mean hair density and the hair diameter. That means it's significant. Please see the next line. Though the mean hair density increased in the minoxidil group as well, it was not statistically significant. Obviously, we need to do more research about it to really document that this is 100% true, but PRP is still working in some format or other, if you see. Another study of platelet-rich plasma injection treatment of androgenic alopecia through a 1-year period. This was a study, and just to tell the highlights of it, the hair density reached a peak at 3 months. That is P again less than 0.001, which is statistically very significant. At 6 months and at 1 year, it was significantly increased. Again, P less than 0.1, comparing to the baseline. Patients were very satisfied with a mean result rating of 7.1 on a scale of 1 to 10. No adverse effects were noted. This is published in JCS 2014. So that means, again, PRP does work. This was the article we had published for alopecia areata, again available online, Indian Journal of Plastic Surgery 2015. So we had done a study on chronic alopecia areata patients. Again, comparing to triamcinolone, it really gave a better result with no side effect as compared to triamcinolone. Couple of other studies. In 2006, Dr. Ubail, Dr. Carlos Ubail from Brazil he was one of the first to use PRP along with hair transplant. They demonstrated an increase in follicular density after 7 months of FUT by keeping the follicular grafts in PRP for 15 minutes before implantation with saline as a control. Greco et al. Has also shown a very significant increase in hair diameter and density. This is a very good study, randomized double-controlled trial, passive and actively controlled half a study, which evaluated PRP in 45 patients of alopecia areata. Again, they compared it with intralesion triamcinolone, and they found that it showed a much better and promising result, and there were hardly any side effects in the PRP group. This is published in British Journal of Dermatology, 2013. Lee et al. Suggested that PRP activated increases the proliferation of extracellular signals and kinases, and they'll stimulates the hair follicle. Also, the anti-apoptotic protein is activated, the levels are increased, thereby improving the anagen phase. And PRP does improve the cutaneous ischemic conditions, which helps in hair proliferation overall. Not going on to RCF in detail. Let's go. So how I do it, I'll just quickly go over that. So it's a preparation which is, when it's ready, we have to use within 30 minutes. We give the local anesthesia much beforehand. We use insulin syringe for administration, injected in the subfollicular plane. And we check the vitals and send the patient back. So typically 4 to 6 sessions is quite adequate. And obviously it's a combination multimodality treatment. It's not a monotherapy which has to be advocated. And you have to do regular follow-up of the patients. Revisits every 4 weeks. Total of 4 to 6 sessions. Follow-up at least 1 year, and later on whenever the patient can come to you. Photographs to be collected every visit, because nowadays we all know medically it is very important. So document every case. So these are some of the pictures. I'll not waste time. Females. Just to conclude, platelet count is the key. That means the platelet concentration, which I was talking about, is the key to success for a good PRP to work. So therapeutically, that's the most important. So at least 300% increase should be there. And I generally use a double spin technique. People do use single spin. Yes, you get result with that, but if you use double spin, we have seen it gives much more better results as compared to single spin. Again, when you're a beginner, you have to do a quantitative and qualitative analysis to make sure whatever protocol you're following at your own setup, it has to be replicated, and it should give a uniform result over a period of time. Obviously, confounding factors of the patient are there, so you have to rule out that and check the hormonal status and other status of the patient along with the modality treatment. It's an autologous treatment with no side effects. A very important effective tool for hair restoration, not only for thinning cases, but also as an adjunct to hair transplant. Thank you everyone for your kind attention. I'd like to thank my teachers. Thank you.
Thank you, Dr. Singh. Next up, I think Dr. Dua's talk is going to work. You're good? Okay.
There's no
So-
video, but some logistic issue.
All right, if you want to start talking about some things as it comes up.
Yeah. So can we have the slides, please? Not a second time non-starter. So it's an introduction to the ISHRS. So most of you do know about ISHRS, but still there are some young people who might not be knowing about ISHRS. So currently I'm the treasurer of the ISHRS, and I am representing ISHRS as the ambassador, ISHRS ambassador. So ISHRS is one of the largest organization of hair transplant surgeons all over the world, as most of you know. So it was incorporated in 1993 with around, and now has got around 1,100 total members. It comprises of physicians, scientists, as well as the surgical assistants. It's a global society, and almost all people, all doctors of all specialties do form a part of the ISHRS. So when we say multi-specialty, the plastic surgeons are one of the maximum number, 26%, dermatology around 23%, and general surgeons form the 3rd%. And as we go down, there are less and less of people. Anesthesia, internal medicine, ENT, orthopedics. So all people are a part of this society, because internationally the guidelines are such that you can practice any field of medicine after doing a proper education and after licensing is available. So it's a global organization with 70 countries, and now as the time has progressed, we have around 70% of our members are non-US and 30% of people are from US. If we see region-wise, US is 30% and Europe is 23% and Asia is 23%. And if we see country-wise, I think after US it's Korea and third is India. So India has around more than 50 members, which is the third largest as far as the membership of ISHS is concerned. Now the purpose of the ISHRS is to advance the art and science of hair restoration surgery, encouraging continuing medical education, increasing public awareness, and promoting professional excellence. The mission statement, it's a global society of physicians committed to improving patient outcomes by promoting member education, collegiality, research, ethics, and public awareness. And the main three pillars of ISHS have always been education, research, and collegiality, and the core values are ethical conduct, free exchange of knowledge, pursuit of excellence, honesty and integrity, and diversity. Education. In education, we have the following programs: World Congress, World Life Surgery workshops, regional workshops which are organized in different continents, fellowship training programs in which you can go to a certain doctor who is a fellowship director, you can apply to them, and there's a 1-year fellowship. Then we have the enduring materials like the Basics in Hair Restoration lecture series. It's an online format for all those who are beginning. They can use this material for getting used to the world of hair restoration. Advanced board course, review course. Then we have got some surgical DVDs and webinars which you can always get an access to. Initially, forum used to come only in the printed format, but over a period of time, we have developed the EPUB as well. In the research, ISHS has funds of around $20,000 annually which can be utilized. And apart from this, this year we have also started with a travel grant of around $10,000 US. There are various committees which have been formed to promote research, including the FUE Advancement Committee, and previously I was also part of this committee. FUT Guidelines Task Force, PRP Committee, Finasteride Advanced Events Task Force, and support for the World Congress for Hair Research. One of the contributions of ISHS to the FUE terminology was that it was changed from FUE extraction to follicular unit excision. This was done last year because excision is a combination of incision plus extraction. In the public awareness, we do have the Communications and Public Education Committee, which you will see that we are doing a lot of activity to prevent the illicit fraudulent hair transplants. We do issue the practice census surveys, consumer surveys, international news releases, and we have our ISHS website by the tag www.ishrs.org. So this is what we have been standing for, and in the past couple of years, we have been trying to promote that only doctors should do the excisions and only doctors should do the surgery. So we came up with this 2 years back, and last year we have started this campaign of Fight the Fight campaign, which is now the cornerstone for the ISHS. So it's an acronym for Fight the Fraudulent, Illicit, plus Global Hair Transplants, because you would have heard that a lot of people are doing a lot of unimaginable number of grafts in the hair transplant, and most of that work is not being done by the doctors. So the patients have been put at risk, leading to a couple of deaths in different parts of the world, as well as kind of the side effects or the necrosis or the infections which were earlier unheard of in the field of hair transplant. So it has been launched globally in 5 languages, and the campaign assets include, we have the following pictures which have been put up on the social media. You can appreciate fraudulent doctors performing illicit surgeries. Yesterday she was a butcher. Then is it the surgeon doing the surgery or the real doctor who is doing the surgery? And a couple of more. There are a lot of people in different parts of the world who are just not doctors, but they are doing different jobs, maybe a driver, maybe a butcher, or maybe somebody who is not trained enough, or maybe just serving. So cheap hair transplants, how can they be so cheap? They advertise the rewards, but we always guide the patients to know the risk before moving to all those places. We even had this pledge by the ISHRS, which was taken up by a lot of doctors, and we are trying our best to spread the message of Fight the Fight campaign. Moving on to the collegiality, I would like to share that it's a very big network of peers, and myself coming from Asia and without nobody knowing me in the ISHRS a couple of years back, I now feel that ISHRS is a big family, and we are all, it doesn't matter which country you belong to, you are an Asian, you are a European or an American, so you are all doctors over there, and collegiality is one of the strengths of ISHRS. Participation in meetings is possible for all of us, and that's a place where we do networking, share our information, knowledge, and ideas. And we have the Global Council of Hair Restoration Surgeries. The Global Council was formed in 2003 by 8 countries. And then India, when I was a secretary, we joined in 2012. And now, last year in 2019, we had around 26 national associations which have become a part of the Global Council of Hair Restoration Surgery. And this is a picture of all of us. Anil, you can see with all the enthusiasm sitting in the center. So all of us after the wonderful meeting of Global Council of Hair Restoration Surgeries. So I would like to invite all of you, those who are not the members, to join the ISHRS, and the application forms are available at ishrs.org. And we have a couple of meetings lined up. Panama, Sam has already told, the deadline is just around the corner. Travel grants have talked, 360-degree workshop, and then there is going to be a workshop in Athens from 12th to 14th of June. Thank you very much.
Yes, I highly support and encourage joining the ISHRS, which I'm very passionate about as well. Thank you, Kapil. Next up is Dr. Rajendra Singh Rajput, who's going to talk about the role of nutritional supplements in overall management of pattern hair loss.
Good afternoon, everybody. We have already had some discussion on this topic in the morning session, and that was pretty much in detail. I'll try to bring out another perspective of the same discussion in this presentation. So, beginning to speak about pattern hair loss, what exactly do we consider or we define as pattern hair loss? The common criteria which we include for pattern hair loss is that it is non-scarring, it is reversible progressive thinning, it follows a pattern, means mainly affects your frontal and vertex regions. It comes ahead with the altered terminal to villus hair ratio. The ratio between terminal to villus hair is altered. Your villus hair or miniaturized hair start becoming more and the terminal hair become less. There may not always be a genetic history. It may be showing androgens or androgen dependent or non-androgen dependent. And many times now it is recognized not to follow a pattern also. So we also have a diffuse unpatterned hair loss. It could also be diffuse. So now this was the older focus, and the older focus is on the terminal hair, is on the end product of the hair cycle or the terminal hair itself. But a lot of process or a lot of background metabolism, actions, cells, cell division, formation goes on for producing the terminal hair. So now as the focus is changing and as we are getting into newer and newer insights on hair loss, people have started thinking about the progress behind the formation of the terminal hair rather than thinking only of preventing miniaturization of the terminal hair. And that is where the role of nutrients and setting the cell functions right is gradually coming into picture. So current research is focusing on this. Mainly, it is the shortening of the anagen phase and extending of the telogen phase that is causing the disproportionate ratio and is leading to miniaturization of the follicles. And there are many more ways apart from the DHT in which this can happen. Apart from only androgens or only DHT, there are many more ways in which you can have shortening of the anagen and prolonging of the telogen. So DHT is one of these many interdependent or intertwined mechanisms that can influence hair loss. We have many other factors that can influence hair loss. Now, what is recent research throwing at us? We are seeing that there is a lot of overlapping pathology with the pattern hair loss or the androgenetic alopecia that we see. In year 2000, we have a description of fibrosing alopecia in pattern distribution. So our basic premise that there is a scarring alopecia and there is a non-scarring alopecia, there is a pattern alopecia and there is a non-pattern alopecia is becoming vague. They are overlapping a lot. So in 2000, we have a new category of alopecia saying fibrosing alopecia in pattern distribution. So here you have the fibrosis, you have the cicatrization plus the following of the pattern. Following which they said this fibrosing alopecia in pattern distribution has close resemblance with lichen planopilaris as well as androgenetic alopecia. So the criteria on biopsy on histology of both are found in the same condition at the same time. It's difficult to distinguish which one is predominant. Again in the year 2000, we have a report saying that this frontal fibrosing alopecia that we see very often now is a type of fibrosing alopecia in pattern distribution which is following the pattern of male pattern hair loss. So you have a fibrosis occurring in male pattern hair loss which is affecting the frontal region. In postmenopausal women it was first noticed, and this now is becoming the new pattern alopecia. Olsen described cicatricial pattern hair loss, a proper condition saying this is pattern hair loss which is occurring by cicatrization of the follicles, but following pattern hair loss. Again 2016, you have a report of a new subtype of lichen planopilaris affecting villous hair and mimicking androgenetic alopecia. So clinically you look at the person, this looks like androgenetic alopecia, you want to do a histopathology and you find that this is showing all the signs of LPP, lichen planopilaris, underneath. 2017, you have a report saying lichen planopilaris is mimicking androgenetic alopecia or pattern hair loss. Again 2017, you have a description of familial cicatricial alopecia which is FFA in pattern distribution. So I want to drive your attention to why these boundaries are becoming vague and why one research person after the other is giving you these reports being published. In 2018, you have description of diffuse scarring alopecia in female pattern distribution. So this is not just a fluke that one person is saying, they are seriously reporting these things. In 2019, there is a publication of rapidly progressive diffuse fibrosing alopecia. And now there is a report saying that normal appearing scalp in lichen planopilaris or frontal fibrosing alopecia are also affected. It means I do a trichoscopy like this and I find that this is the inflamed area or the scarring area where the follicles are not growing. This is the non-scarred area or the scarred area still where the follicles are growing. Underneath pathology is the same all over the scalp. Then we come to the next question, why are few follicles growing and why are few follicles being cicatrized and unable to grow? The answer is in understanding that in humans, the hair growth is asynchronized. In lower animals, you molt at the same time, your hair falls at the same time, it grows back at the same time. We have lost that ability in evolution. Here, the hair growth is asynchronized, each follicle stands for itself. So if you're pushing two follicles with the same force, the weak follicle is the one which will fall, the strong follicle is still capable of withstanding those changes and continuing the growth. So this is a strong follicle that in the same inflammation or in the same environment is continuing to grow, whereas you have a weaker follicle which then suffers and falls. But if you give nutritional support to these follicles and you restore their cellular function and support them to grow, you will find that all of them grow uniformly in the same pattern. Whereas clinically, if you are doing trichoscopy, this is the hallmark of AGA, is finding anisotrichosis where one follicle next to the other or two hair in the same follicular unit are growing at different phases. We need to understand this. So can we improve this cellular response or the strength in the cells to withstand these changes? What do you mean by the cellular response? We always say that DHT levels are not important, but the response of the follicle to DHT is altered, which is giving us the hair loss patterns we are seeing today. What is the altered response? The altered response is inflammation, immunity, and genetic expression. These are being altered because of various factors. So can we improve the inflammation, immunity, and genetic expression by nutrition? Yes. We have reports that omega-3 fatty acids, polyphenols can reduce inflammation. Autoimmunity, they can counter interleukin 1, interleukin 8, they can downregulate inflammatory gene response. These are published reports by 3 different workers, 2012, 2018, 2002. So these are proper studies conducted where these agents are seen to work. Vitamin D, zinc, magnesium, selenium, coenzyme Q10 can reduce inflammation. Reports coming in 2015, 2016, 3 reports in 2018, where people have worked on these agents to prove scientifically that use of these agents can reduce inflammation. We know that protein energy malnutrition can lead to breakdown of your immunity. We also know that you replace the protein energy malnutrition, you correct it, you can rebuild the immunity. Micronutrients influence gene expression, genetic response to inflammation, immunity, and antioxidant activity. Again, reports in 2004, 2012, 2014. So we have a specific defined role of micronutrients. There are 2 new branches of medicine coming called Nutrigenetics and Nutrigenomics. Nutrigenetics is the effect of nutrients on DNA, Nutrigenomics is the effect of nutrients on gene expression. If you have damage to the DNA from various external and internal factors, what do you is required for repair of the DNA? You require amino acids, zinc, selenium, iron, B6, magnesium, that is required for repairing the DNA sequences again. So at the cellular level, at the nuclear level, there is a requirement and specific defined role of micronutrients, apart from commercial interest, because somebody said, don't go for nutrients unless you have got commercial interest. So there is no commercial interest here. So micronutrients can strengthen the cells, restore the functional cellular environment in the body, and correct the weakness of the cells. Now here I want to say that DHT comes out as an opportunistic intruder. Your DHT levels in the person are normal. In your patient who comes with hair loss, the DHT levels are normal. But you see effects of DHT on cells which are weak. If you restore the strength to the cells, you can take the protection and save the cells from being affected by the DHT. So this is the point that I would like to make. The DHT is an opportunistic intruder. You improve the internal cellular environment, restore the homeostasis and function of the cells. You can protect the cells from action of DHT, because all the hair on your head is not falling at the same time. One hair next to each other, you will see one is affected, the other is already being protected. So give better protection and strength to the cells is the answer, not fighting the DHT. Oxidative stress has got role in so many conditions. It is mediating the action of DHT, mediating substance P. It is mediating activation of TGF-beta. And nutrients also have a direct role. Vitamin D, we have seen, has got direct role on dermal papilla. Omega-3, omega-6, we have seen. Zinc has got multiple benefits. It inhibits catagen, acts as immune modulator, inhibits regression of the follicle in telogen. Copper is required for differentiation of dermal papilla cells. Arachidonic acid promotes mitosis. But these nutrients interact with each other. You have to give them in the proper proportion and proper synergistic action, which requires specific formulations. If you understand that, this is the kind of results you can get. Thank you.
Thank you, Dr. Rajput. Next up is Dr. Venkatram Mysore. He's going to be talking about stem cell therapies for hair loss, review of safety and efficacy.
Well, I have to make a disclaimer right at the beginning.
Good morning, everyone. I'm Dr. Aniket, and I will be speaking on the importance of aesthetic fellowship
happened? Okay, okay. Right. I'm not an expert on stem cells. I have not used them. My interest in this is more like a student. So, that sense that I have learnt while preparing for the talk, and hence I am grateful to the organizers for asking me to give this lecture, which they basically did because they could not find anybody else to give this talk. And then I have to acknowledge the contribution of my fellows who helped me prepare this lecture. Now, these are the things that we need to understand. Stem cells, what is a niche, signaling pathways, their role in hair follicle regeneration, what are the stem cell sources apart from hair, what is the method of extraction and their applications, and what is the legal position as of now. Stem cells are cells with the ability to maintain themselves and proliferate and produce progeny that can undergo differentiation. So this, in a sense, a very complicated slide, summarizes what I said just now. The stem cells will produce progenitor cells, which then produce different types of differentiated cells, and then there are various signaling pathways which are involved in this, which we have heard in the morning, WNT, Notch, so many other signaling systems, and all this happens in a particular niche. It cannot happen elsewhere. So these are, the niche is actually a small microenvironment wherein the stem cell can become functional. The niche will include the location, as you can see here, the bone marrow niche, neural niche, hair follicle niche, as you can see here, fat is another niche. So there are different niches where stem cells are operating. So if you want stem cell to work when you treat hair, you have to deposit the cells in that particular niche only. You guys can't inject somewhere else and hope that the hair will grow. Now, why is this so important? It's important because we are understanding more about the molecular signaling pathways in these cells, and then the effect of paracrine and endocrine functions in human hair growth. And we are hoping that by doing all this, we will have a simple injection of stem cells which can produce hair. And these are all the indications where the stem cells can work. Not just androgenetic alopecia, but also other types of alopecia, particularly cicatricial alopecia, where the hair follicle is completely destroyed. Even vitiligo and leukoderma, all these are places where stem cells could work. But the problem is hair is very complex. It has different types of cell populations which proliferate differently and mature differently. And importantly, it is cyclical. As you can see here, it cycles itself. And it has components derived from multiple sources, epithelium, mesenchyme, neurectoderm, etc. So, what are we trying to do here? One is, we are hoping that we will reverse the pathological mechanisms in androgenetic alopecia, that we will try to regenerate hair follicles in cicatricial alopecia, and then perhaps we can create hair using the tissue engineering approach. Now, the niche for the hair, the most important niche is what is called the bulge. Here, just at the site of attachment of rectospinorum muscle, which contains not only the hair follicle stem cells, it also contains epithelial and melanocyte stem cells. These hair follicle stem cells are also located to some extent along the outer root sheath and proximally towards the isthmus. The bulge is just a name in human beings. It is really a bulge in mouse and other animals. In human beings, it is not a bulge, it is just a location. This is to be understood. So now these different types of stem cells are present here. There is also one type of stem cells in the upper part, in the infundibulum, which is responsible for the production of the epithelium. So if there is an injury, That is where the epidermis comes from. Then you have a dermal papilla where there are other types of stem cells. These all can be identified different markers, of which I am not an expert, so I will not go into this, but that is how they are identified. Now the other loci for stem cells include the isthmus region, the so-called intrafollicular epidermis and sebaceous glands, the dermal papilla cells, which are basically mesenchymal origin, and then melanocyte stem cells within the bulge. The dermal papilla stem cells play an important role in the induction and regulation of hair growth. Remember, during the telogen phase, the inferior segment disappears. So the bulge comes in close contact with the bulb, and that is when, through signaling pathways, the dermal papilla cells influence the bulge cells. It is the dermal papilla cells which are of great interest to scientists because they are mesenchymal stem cells and they can differentiate into other cells such as adipocytes or osteocytes. So they are an easy source of pluripotent stem cells. The extracellular matrix is another component of this microenvironment, and it directly affects stem cells by the formation of basal cell membrane. So the hair follicle stem cells, dermal papilla cells, extracellular matrix, all are important for proper hair recovery and regeneration. Now we have seen this in the morning, the various pathogenetic explanations for androgenic alopecia. Now in androgenic alopecia, the hair follicle stem cells are well preserved, but the progenitor cells are decreased in number. So this is the reason why androgenic alopecia is reversible, whereas in scarring alopecia, they are completely destroyed, and so it is irreversible. Now in androgenic alopecia, as we have seen in the morning, the balding scalp either lacks an activator or has an inhibitor of hair follicle growth, and that is why the process is irreversible. Now what are the sources of stem cells that we can look for in hair regeneration? One obvious source is the bone marrow, but it is impractical for the reasons that I have mentioned here. Wharton's jelly in the umbilical cord is another source for various reasons I have mentioned here, easily available, no moral issues, no immunogenic potential, and this is something which is of great interest to scientists, but that is still not for practical use. So we are basically concerned with these three: scalp and hair, PRP, and then fat, which will be covered in the next lecture. Now here two things are important. While preparing stem cells, FDA has defined one minimally manipulated biological products, that is centrifugation, filtration, isolation, teasing of cells mechanically. These are allowed to be performed by physicians. So PRP is safe, fat transfer is safe, these are safe procedures. And same thing we do in vitiligo also. But there are others called manipulated biological products which are through culture, etc., and that requires special regulation. Indian Council of Medical Research also has come out with a document stating these things very clearly. That particular document is available on the HRS website. Now, platelets, there has been a discussion. Now, this particular paper is very interesting. It states that if the platelet sonicates, process of sonification, which is repeated centrifugation, is used instead of a activator such as calcium gluconate, that kind of a platelet lysate activates hair follicle stem cells better. So in that sense, PRP is not just a source of growth factors, but it also may activate stem cells. So this is one of the easiest ways of activating stem cells. Now, Sukhbir referred to the papers on this. I was actually referring to this paper, which has been published in IGDVL in the latest issue. Here they studied 4 groups, 84 patients, minoxidil alone, PRP alone, PRP and minoxidil, and saline. And they concluded that PRP with topical minoxidil was the best. PRP alone and topical minoxidil alone were equally effective and superior to saline. Saline, of course, led to deterioration. So these suggest that PRP may also have some role. Now this is the Regenera which was discovered earlier. This is the paper that I was mentioning in my morning comments on this particular topic. Now here, please note these terms. stem cells from human hair follicles. And then first mechanical isolation. Now that is the differentiation here. Mechanical isolation of stem cells. This is the first paper on that subject. In that sense, it is very interesting. Whether it is effective or not, that's a different issue. But they try to isolate stem cells by mechanical means. In vitiligo surgery, we do both an epidermal cell suspension as well as a follicular cell suspension. But there we use enzyme. We use trypsin to lyse the cells and separate them. Now here, this is the device wherein you put a scalp biopsy and then you centrifuge it, you get an extraction and which you inject here. This is the kind of results that they showed, not at all impressive. Not at all impressive certainly, and there is no proof that it works as it now. But the important thing is that there is some logic to it and the concept is interesting. Hopefully it will develop into something else. But the problem with this product was that it was commercialized too soon without any data, and then the cost was very high. People did it at 50,000-60,000 rupees a session and it was not justified. Now the difficulties in using stem cells is not just about using it, it's about injecting him into the niche. How do you inject it to the outer root sheath? How do you place them in the bulge? This is what is difficult. Stem cells from fat, Dr. Aniket will present in the next lecture, and there it stands a little better chance because they are mesenchymal stem cells and the niche is the dermal papilla, that is the dermis. So there the niche is okay. So it may work to some extent. So now to summarize, this is a very exciting prospect. Obviously we are going to hear more and more about it. Some progress has been made. Hope one day injections will produce hair. If that happens, we all will lose our job. But don't worry, that day is very far away. Thank you very much.
Thank you, Dr. Mysore. Next and last 10 minutes up for this one is Stem Cell Therapies for Hair Loss, Role of Fat Stem Cells by Dr. Aniket Venkatram.
Good afternoon, everyone. So I'll be speaking, it's more of a continuation of the previous talk on the role of adipose-derived stem cells for hair restoration. So I have no financial disclosures to be made here with regards to any of the products that are being described. So to begin, initially when fat grafting evolved as a technique, its main aim was to treat volume loss. It was developed as an alternative to fillers and implants. But it was noticed that often the transferred fat improved the quality of the overlying skin, particularly in the face. So hence focus shifted on exploring this regenerative potential of fat through adipose-derived stem cells. Now what is fat made up of? Obviously adipocytes, but also various other cells such as pre-adipocytes, fibroblasts, stem cells, various progenitors, endothelial cells and immune cells. Now of all of this, what we are most interested in is the adipose-derived stem cells. So what's the big deal about them? They're exciting because they can induce production of extracellular matrix, new collagen deposition and early revascularization. They have an ability to differentiate into ectoderm, endoderm and mesoderm. They produce various growth factors, which was covered very well by Dr. Sukhbir, and all these growth factors have proven roles in hair stimulation. So because of this, the various techniques have been designed or are being designed to obtain a fat graft as rich as possible in ADSCs. What are some of these formulations? To begin, stromal vascular fraction was the first one. In simple terms, SVF is everything in the fat tissue except adipocytes. This includes a substantial amount of mesenchymal stem cells. There are studies which say that the stem cell frequency in adipose tissue is up to 2,500 times more than the frequency in bone marrow. So to obtain SVF from a fat graft, the SVF has to be separated from adipocytes. This is done by first doing lipoaspiration, followed by enzymatic dissociation, followed by several centrifugation steps and filtration. One commercial product or system for this is known as Kerastem. Now, while SVF was good, it was not ADSCs alone. It was ADSCs with other cells. So there was an attempt made to get a pure ADSC concentrate, which is a more homogeneous population. To do this, this is mechanical or enzymatic digestion followed by culturing. So when you culture them, you're increasing the level of ADSCs, and these cells are said to have the ability to differentiate into various lineages. This capacity has been shown in an artificial setting. It has not been explicitly shown in vivo. But despite this controversy, they have demonstrated immunomodulatory and regenerative potential. And studies have found that stem cells from adipose tissue have stronger immunomodulatory effects than stem cells from bone marrow. And the third product from adipose tissue are cellular derivatives. The most famous one of this is AAPE, which stands for Advanced Adipose Derived Stem Cell Product Extract. I think it's easier to remember Aam Aadmi Party extract, but anyway. So this tissue, this is basically a lyophilized form of protein secreted from cultured ADSCs, collected and isolated from healthy adult women. So this is not your own tissue. This is some adult woman, their lipo tissue was taken and cultured, and then they were stimulated in low oxygen environment to induce cytokines. And these cytokines are then frozen and powdered, and in this powdered form, their activity is not diminished, and it can be stored for long periods. They can be dissolved in 4 ml of saline per vial immediately prior to usage. And finally, coming to Nano Fat. Now the others, as you saw, we were getting more and more focused. First you were getting SVF, from there you are isolating specific adipose tissue. The philosophy behind Nano Fat is a little different. The idea is it's not just, you don't need to just transfer the stem cells, it is more beneficial to transfer the microenvironmental mixture of all cellular components, as this intercellular cross-talking brings out the best in those stem cells. So nanofat in simple terms is a mechanical to obtain clinically usable ADSC, some harvested fat using mechanical methods rather than chemical. Microfat is fat with intact adipocytes used for volume loss. Nanofat is fat rich in ADSCs. There is no live adipocytes. It's used for rejuvenation, not for volume loss. This was first described by Tonard et al. In 2013. At that time, it was described for facial rejuvenation. So you harvest fat with negative pressure liposuction. This fat is then sedimented and filtered. It is then emulsified by passing through 2 lower lock syringes with connectors. First a 2.4 mm connector, then a 1.2 mm connector, and then finally through a nanofat filter. These are the connectors, and that is the filter. So once this is done, it is injected using sharp needles. It's injected into the superficial dermis till a blanching or yellowish discoloration is seen. So this is the technique of nanofat. Now post-op with nanofat, you can have swelling, bruising, painkillers and antibiotics might be needed. Now coming to hair. There have been some studies using these products in hair. They are few in number. They are on small patient samples. But let's just go over some of the important ones. One by Shin et al. Was in 27 patients with female pattern hair loss using that AAPE. They applied it by microneedling followed by topical application once a week for 12 weeks. They saw that mean hair density increased by 16% and hair thickness increased by 11%. Perez Mesa et al. Did a study in 9 patients with male and female pattern hair loss. They used a combination of a fat graft with keratostem derived SVF. So they mixed a regular fat graft. This is not mentioned in the paper specifically, but I think they emulsified the fat graft. It is not mentioned specifically. And then this is injected into half the scalp. In the other half, saline was injected. They demonstrated a mean increase of 44.1 hairs per centimeter on the treatment side compared to a mean increase of 1.3 hairs per centimeter on the placebo side. They said that the increase on the placebo side was potentially from the trauma of the injection. Another study by Fukuoka et al. Was by AAPE again on one side of the scalp and placebo on the other. They did this every month for 6 months. And they found that it increased on both sides, more on the AAPE side. The increase in count was 18.4 in 11 mm circle on the treatment side, 6.5 in the placebo side. There's only one study described so far using nanofat. This is done as a single session without any other treatment, no minoxidil or anything else. The outcomes were measured by trichogram. They just described an increase in number and thickness. The paper does not give any numbers or any percentages. It just says an increase in number and thickness. Another study by Anderi et al. Was done in 20 patients with alopecia areata. They used SVF. They don't mention how they obtained this SVF. They demonstrated increase in density by 25% and increase in diameter by 30%. They also demonstrated a decrease in the hair pull test from 4 to 5 to almost normal. Apart from these studies, other studies are pretty much isolated case reports. So these are all promising results, and what is also promising is that subcutaneous, intradermal, microneedle based administration, all routes show to have some level of effectiveness. But there are obviously very few studies, they are very small numbers, and there is no standardization at all. We have started doing Nano Fat in a few cases. We have found it's easy to do along with hair transplant than as an isolated treatment. It's difficult to measure its absolute effect in the absence of drugs or PRP, and we don't yet have adequate data to present, hopefully next time. But some things to be kept in mind are the liposuction harvest has to be done by a trained surgeon. Remember that all complications of liposuction such as deperforation are possible. Unlike PRP, these emulsified adipocytes may have complications when injected intravascularly, so you need to be a little bit more careful with what you're doing. And the patient has to be explained about the current evidence or lack thereof. So further studies are needed to elucidate these mechanisms, ideally rigorously designed RCTs. To conclude, fat grafting is a versatile tool with exciting possible applications. It's still early days, more evidence is needed. There is definitely a lack of standardization, and as of now, it should be done in a research rather than a therapeutic manner. Thank you.
Okay, all the speakers, please stay up, come up or stay up here, and let's start the session. We have 30 minutes. I'm going to be asking some questions, and I encourage the audience either to submit questions or to go up to the podium and ask a question. We'll try to do this in order of each of the talks so that we stay on time. So the first talk was by Dr. Singh on PRP. I would like to ask a question, is that, you mentioned at one point it was multi-therapy. Have you seen as a standalone therapy, just PRP, 4 to 6 session, I think you mentioned, efficacy? And if you have seen that efficacy, how long is the duration? Because you talked about Q4 weeks. I just want to have you elaborate on that for a minute.
Actually, when I started PRP in 2011, so I have actually used it as a monotherapy for a couple of my initial clients, and definitely I have seen good results in that. Because initially I was not using combination therapy like finasteride and all. I was not using, even minoxidil I was using like on and off. But initially, if I talk about maybe initial 50 patients, I have done PRP as a monotherapy. Though I have not published that, but I have definitely used it, and I have used like 4 cycles, like every month 1 cycle, and I have seen improved results over a period of even 1 year. Though I have not documented it, but yes, I have seen improvement as a monotherapy also.
And when do you think you have to maintain it? If you wait a year, do you repeat it
The problem is if we keep repeating the session, actually we can even induce scarring. But every time you puncture, you can actually even induce scarring. So then some amount of scarring can always get induced, and later on fibrosis might set in, may lead to decreased hair growth or maybe more hair thinning later on. So it's always better that you have to do a couple of sessions, then do maintenance with minoxidil and finasteride in long run, rather than keep doing PRP every month, keep doing it.
Okay.
It should not be done that way. I personally believe that.
How many people in here do PRP? Raise your hand. How many people believe they need to do 1 session only? Raise your hand. 2 sessions over a period of time. 3 sessions. 4 sessions. 5 sessions. 6 sessions. Okay, so there's a lot of differences. How many people believe they're very convinced as a standalone treatment it works? Raise your hand. Okay, fewer. Interesting. Okay, so this is why I tried it. I have not gotten great results. I did 1 to 2 sessions, but I actually stopped doing it.
I feel so minimum 3 sessions are required, because the hair cycle, if we see the scalp hair cycle, it's minimum for 3 to 4 months. So before 3 months, I think we should not even think about documenting or even assessing our results. So minimum 3 to 4 sessions are definitely required. And I think there are not many studies now which have documented very clearly that during hair transplant also, as a plasma holding solution, I think PRP works the best, even as compared to any other solution which have been earlier documented, where you talk about saline, talk about heptamersol, but PRP has worked the best. So obviously it is definitely giving you some benefit, if not 100%, but at least a significant amount of it in long run.
What's your concentration and what's your volume? Like 5x platelet, 2x?
At least minimum 3x, sir.
And
3
how
to
many
3.5x.
cc's? How many milliliters?
I usually take about 4 vials. It's about 8.5 ml ACD vials I use actually. So I use about 4 vials of it. So that's 7.5 into 4. If we calculate about 30 ml, I take blood. And I isolate about 4 to 5 ml of PRP also out of that. And then I use that for infiltration.
So about 4 to 5 milliliters.
About 4 to 5
and
ml
about
for whole
3x.
scalp, I require that, yes.
Okay.
Sam,
use for-
can I say something on this?
Yes, yes.
Yeah. Now, see, I too have been using this for almost 4 years. Initially, we used to prepare PRP ourselves without a kit. And then we went on to a kit. And almost till now, my belief is that it augments the effect of drugs. That it may not work alone by itself that much, but in combination with drugs, it works better. We have just prepared a paper in about 85 patients, all of whom had received minoxidil, did not want to take finasteride, and had not responded to minoxidil. Now, our conclusions are that 4 sessions are the ideal setting. Less than that, the number of patients with good results becomes less. Some patients, a small number of patients, may need a 5th or 6th session. How long the results last? Some of these patients have been followed up to about 6 months. So it definitely needs multiple sessions, some kind of maintenance once in 6 months or so, even after these 4 sessions are completed.
Are you doing these standalone or multi-therapy?
No, it is multi-therapy. But the patient setting is only when minoxidil fails. Patients on whom minoxidil has worked, we don't add PRP to it.
Do you add it? So how long have they been stable on minoxidil so that you can read it as a single therapy?
At least again about 4 to 5 months of minoxidil therapy.
Okay.
If by then nothing works, minoxidil is not working, and then we go on to PRP.
Okay.
Now, I quoted one study in my lecture wherein they had 4 arms of patients, one with PRP alone, one with PRP
that
with
was a good
minoxidil,
right.
one minoxidil alone, and then saline.
Right.
And that study is a well-designed study, perhaps the best in my opinion. And I think that study for the first time shows that PRP alone also could have some effect. I'm still not fully 100% convinced, but that's probably the beginning because that study was fairly well designed. Now, there have been almost about 17 or 18 publications of PRP in the last 3 years. Some of them are not so convincing, some of them seem to be good. But the quality of evidence is getting better with time. So, if something is working, then only this kind of a thing happens. Otherwise, people won't publish. It's one of the few areas wherein you have had a spate of publications in the last 2 to 3 years.
Yes.
So that suggests that there is something there. Maybe we don't know fully, but something is happening.
When you do your 4 sessions, when do you repeat it?
Every month. Once a
Forever?
month. 4 weeks. No. 4 sessions. Thereafter, we follow the patient. Patient continues to be on minoxidil.
Yeah. Do you repeat it a year later, 6 months later?
No,
When-
6 months later.
6 months, you wait, and then you do another 4 sessions?
It depends. It depends upon what the patient says.
I have something to add here. I
Yeah.
did a literature review on this topic a little while ago.
Sure.
And I found one evidence-based guidelines consensus paper, which this is the only one I found giving a consensus on this, saying that in their opinion, you do PRP once a month for 3 months, and then maintenance of once in 3 months for a year. This was that one paper's recommendation by a panel.
So after the first 3, then it's every 3 months
For a year.
1 year, and then
That's it. This
no
was
more?
their recommendation.
Ever?
Normally, I like to give every 6 months if required, one session, like a booster session. If I have
Right.
to give, then every 6 months,
Yeah.
I'll be giving 1 session. That's what I do when I follow up my patients.
I think this is a big issue that I'm going to ask is not only the series you do and the concentration and the volume and the methodology, but when do you repeat it?
Yeah,
You know?
so that's why it's very important to
Yeah.
quantify your, whenever you do a PRP, whatever protocol you're following, it's very important to quantify and even qualitative your analysis.
Yes.
So what I've published in my study also, we have done all the patients who underwent quantitative and qualitative analysis by pathologists independently, and they have checked the smears also to quantify which is working, which is not working, and how much is the quantification quality.
Yeah,
That's very important. So
and
once
then-
you validate your protocol, whatever, you just follow that. That's very important.
And then the question is obviously, I know that study had microneedle, but the question is if you're injecting with PRP, you have a needle stimulation, and are you not activating it? Because I always activate it, and then I've got microneedle, and it's confusing with what's happening.
Sir, I have a reason for activation because when I add calcium, so I know how much I'm activating it in the right concentration. Because
So you use chemical.
I'm not waiting for a tissue to, create that stimulation.
Right.
Because that might be different in different places, or maybe there is some inflammation going on in some area. It might hinder the result. So I'm actually activating prior hand. So I know how much activation I've done and what I'm trying to achieve. So
Right.
that's my philosophy of doing activation beforehand. I mean, I always use activation.
Okay.
I never inject without activation.
Okay. We're going to, next topic is, question, comment? Yes.
In the presentations in the morning, every one presentation mentioned TGF-beta as a pro-apoptotic factor. You are precisely delivering a lot of that in this. So how do you rationalize it? When I know TGF-beta is a pro-apoptotic factor, it is implicated in the entire cascade of events which finally leads to miniaturization. I am putting in a lot of that in this. That is the first point that I want to ask. Secondly, at what depth do you deliver your PRP?
Subfollicular plane, sir.
Pardon me?
Subfollicular plane.
So
just
generally
beneath
what
the
would be
dermis.
the depth?
Intradermal. I mean,
No, in
3
terms
to 4
of millimeters.
Not the half of insulin syringe. If I say talk about insulin syringe, it's half the needle depth. Obliquely we
So
enter.
once I have delivered this, what do you think is the outcome of the growth factors there? How long do you last? How do you think they last there? And how do you justify 1 month gap for the next injection?
Sir, we have to give minimum healing time. That's very important.
No, but
Whatever
I am asking, is there an understanding of that? Because it is very ambiguous from what I am listening to, that everybody has something, but there is no rational basis for it.
First of all, we are following the patient. I mean, it becomes
No,
easy follow.
that is a different aspect. I am asking very specifically, do you have an idea what happens to the growth factors there, and what is the time for the biological half-life there? How long do they last? And when do you
The release
decide to
of
do the
growth
next
factor-
one?
The release of growth factors starts at 4 to 6 hours, and it maintains like first 24 hours the maximum spurt of growth factor which occurs, and then it is maintained. So I think we have to allow that healing time to occur. So 3 weeks is the minimum time we have to wait, I feel personally.
See, in a treatment like this, I think there is a process through which the evidence gets accumulated. Initially, there were some stray case reports. Then there were some studies which were not of good quality. Now we are getting studies which are of a better quality. So hopefully, if it goes on like this, in another 2 or 3 years, we will have every single answer. Now, has anybody injected PRP and found out what is the concentration of growth factor inside the skin? How long it will last? Obviously, no.
No, obviously, that is not. I am just asking from the point of the duration of your, spacing
if you accept that particular paper, which suggested that it could activate the stem cells also, then that takes it to a different plane.
No, the thing is that
Again,
is a different
paper, it's a
issue.
discussion. No, what I'm trying to say is that it is not just the growth factor directly acting on the hair follicle cells. It's also these growth factors which are acting on some components of the stem cells. Now, there was another paper wherein that particular paper compared PRP alone with dermaroller alone, microneedling alone. So that takes care of that question whether microneedling is inducing hair growth. Now, the point about this particular subject is there are continuing studies which are getting published in different types of journals, peer-reviewed journals. All the answers are not there. Hopefully, in another couple of years, there will be better answers.
The reason I'm asking this is that PRP was used for many years or many decades earlier by the orthopedic surgeons, the dental surgeons, and certain other allied specialties. There was a period for about 5 to 6 years when there were a lot of publications, and it gradually died a natural death because rationalizing I know how the problem is occurring to some level, and I'm just putting in growth factors that doesn't solve the problem.
Okay.
And there is a huge conflict of interest on part of the doctor delivering this treatment as compared to the study that you mentioned between PRP and minoxidil. Both are practically the same. Again, here the evaluation of the outcomes will have the subjective response which decides a huge placebo effect on part of the patient when something injectable is done versus something that is applied. And that kind of skews the whole outcome in terms of results and the benefits that the patients
But
give.
in that case, there is a saline arm also for the placebo effect?
Okay. Those are let's keep going. Those are good points. Be very short in this answer. Dr. Singh, how do you anesthetize the recipient area for PRP? How do you anesthetize the
I
area?
just give a ring block. That's it.
Next question, Dr. Singh. How do you prepare in a patient with hypertriglyceridemia because there is a cloudy concentrate which forms? Hypertriglyceridemia. Any issues?
See, we evaluate all our clients, and if there's any metabolic disorder or anything, we refer to the physician or the endocrinologist. He takes care of that. Then only we start treatments. We never treat a hair patient isolatedly. You know, if he has got thyroid disorder or any other disorder, obviously we treat that beforehand. Then only we start the treatment. We never just a patient comes to us that we'll start all the treatment. I think it's not practically possible. If patient has PCOD, hypothyroid, or any other problem, especially females, we have to treat that disorder. How can we jump to just doing a hair treatment without treating the disorder first of all?
Okay. Is there a real difference in clinical response with concentration of platelets? Any studies done, opinion of panelists? Is it okay as long as it is 3x, or does 3x, 5x count really make a difference?
Yes, there are a lot of studies which have been documented that, in fact, one of the initial starters who started, Dr. Kalik et al., I think, if I remember well, he had published and compared that 1x, 2x, 3x, 5x, 8x, and then he concluded that minimum 3x is required for a therapeutic PRP. To qualify as a therapeutic PRP, that means it will work. That is the minimum concentration which is required.
Got it.
He even checked that even a concentration of 5x, 8x was not superior to 3x. It was almost equal. So there is no point trying to
go
achieve
beyond
5x or
3.
8x.
Okay.
Then they even compared double and single spin, you know. That also has been compared.
All right. When do we see minoxidil finasteride effect on miniaturized hair? I would just answer that and just say it's usually several months that we see that. When do we see results of PRP on the same miniaturized hairs? When do you see the effects of PRP?
Yeah. I think minimum 3 months have to be waited. We never quantify whatever result, whether we are giving nutritional support, PRP, or minoxidil, or a combination therapy. At least 3 months have to be waited because the hair cycle has to complete. So we have to wait for that much time minimum.
Okay.
That's the minimum duration.
Dr. Rajput, any practical tips of like how do you talked about a lot of different products. Anything that you could tell the audience, this is how I do it?
The practical tips that I generated over my 25-30 years of practice is now created into a ready-to-use therapy. All of you know that. I shared it openly with everybody. So you require antioxidants, iron, calcium, amino acids, B complex, biotin, omega-3, everything. What you do is don't dump all that on the cell at the same time. Your cell cannot use it. And these nutrients compete with each other for getting into the system. They reduce the efficiency of one another. That were the last 2 slides that I was coming to, is internutrient interactions. So we combine them synergistically. These nutrients also help each other to work better. So we have 2 nutrients that help each other to work better on Monday, 2 on Tuesday, 2 on Wednesday. You break it on different days. So the dosage is less, but the efficiency is better. You can continue it for a long time without any fear of overdosage, and also you reduce the cost of the therapy.
Okay. And what is the most important thing to start with? You said they compete. What do you start with, and then what do you add on? In what sequence do you go through that?
Start with the antioxidants first, followed by iron, folic acid, vitamin C, followed by amino acids and omega-3.
Okay.
And if you know that your client is having vitamin D3, B12 deficiencies, we give a single dose of vitamin B12, D3 therapeutic dose on Sundays.
Which antioxidants do you use, and how long do you wait before you scale them to the next step?
Will be a very detailed answer. I'll say I got all my publications on ResearchGate. Just search, and each and every detail along with the formulation is published. Also published in the forum, along with a table that gives you the content of the antioxidants we use.
Okay, to Dr. Mysore, what is the possibility of converting stem cell to malignant cell? Anil Garg.
This is obviously one of the worries while using it, and that is why one has to be extremely careful before this kind of thing becomes a practical tool. This is why several guidelines have been published, and about 3 or 4 years back, ICMR came out with a publication saying that people have to be careful while using this. So that is definitely a worry. But I showed what the FDA allows with minimal manipulation and what FDA does not allow with significant manipulation. So that worry is more for the ones wherein you modify the cell, you culture the cell, you alter the cell, etc. As long as it is a simple transfer of an existing cell, that is supposed to be safe. Now, we have been using this in vitiligo for decades now. First as a epidermal cell suspension, and then as a follicular cell suspension. Fat transfer has been practiced for decades. So these have not led to malignancies. In fact, I am aware of only one publication wherein a particular preparation injected into dermis generated a benign hair follicle tumor. That is the only thing which I am aware of. Otherwise, I am not aware of any such thing that is done in this. So as long as the cell is not manipulated, I think it is safe.
From what I've understood is if it's distally injected, there's a more systemic risk of malignancy versus local injection. And if it's just fat, I don't know if there's been a reported case, but it's more of a stem cell injected systemically, like in Korea, where someone that has a predilection toward cancer could develop that cancer, as far as I understand. Are there other safety issues? Your title of your talk talked about safety besides malignancy that we've just talked about. Are there other risks that people should know about?
Mutagenicity this is one of the things, carcinogenicity, mutagenicity. These are the ones which have been looked at carefully. But all the things that are being discussed in relation to hair follicle is actually a non-manipulated cell. Dr. Aniket might like to say more.
The one thing I would like to add is the one risk is, unlike PRP, if you inject this intravascularly, you can cause, like whatever you have with the filler, you can cause endoarterial necrosis. Yeah. So that is one risk that should be kept in mind.
There was one case of blindness recently published wherein a doctor injected PRP with fat and it got into the vessel, and just like a filler, it can relate to vascular episode. Embolus.
Interesting. So was it a nano fat, or was it would you say?
It was not documented in the article.
It was not documented. The question would be, is nano fat acting like a liquid, or is it something that can still obstruct the retinal artery?
It is acting like a liquid. You are able to inject it through 26, 27, 28 gauge needles. But if it goes into, there are collagen particles as well. That's the reason why that nano fat filter is part of the preparation process. If you don't use that filter, you have collagen particles, like discrete collagen particles. So if that goes into a small enough vessel, it can definitely cause a blockage.
So that still can cause an embolus. Okay. That's a very good thing to talk about. The question, actually for both Dr. Mysore and Dr. Venkatram is longevity. It's a question I asked for Dr. Singh as well as this PRP. I didn't hear a lot of talk about that. I heard a lot of talk about all these studies with Fukuoka, Perez Mesa, Andre, et cetera. But the question is, the reason I framed this is that I had an article I reviewed. I accepted actually, maybe, I can't remember who wrote it. I couldn't talk about it because it was embargoed, but it got recently published, so I can state this. And in this study, I cannot recall what type of fat it was injected, but they showed a statistically significant improvement at 6 months, but it returned to baseline at a year. So the reason I ask this question is when you start looking at PRP, that's relatively less invasive, drawing blood and then spinning it and injecting it, although that's still cumbersome compared to like exosome therapies because that's out of a bottle so per se. But fat, if it's out of the body, is higher morbidity and a higher interval time. And if at a year you're seeing a return to almost practical baseline after a single session, even though there was a good benefit at 6 months, because doing that every month is hard. You have to freeze it. You may have tissue bank issues. So the question I have is, do you remember any of the studies in terms of longevity and when to repeat it?
No, absolutely none had any comment on longevity. And they varied widely in terms of the treatment protocol as well. As I said, one was a single dose, one was once a month for 6 months, one was once a week for 12 weeks. There is no standardization. It is right now, it's kind of like the Wild West. People are just trying things and seeing what sticks.
Right, and that's a big concern is the level of morbidity. If it doesn't give you really protracted longevity, first high efficacy, high safety, and we've already talked about some safety issues that are quite problematic, even although rare, is how the heck long does it last? You know, if it's lasting 6 months and there's risk and morbidity, why do it is a good question. We forget, so that's my real driver is talking about longevity on these therapies, because you've got to factor that in. Efficacy, safety, longevity, of course legal issues.
But longevity can get established only with time.
Yes.
And that can only happen if people keep trying.
But what I told you, the only study I reviewed showed that.
No, but these are all studies which are initial studies.
Yes.
So, for example, in the early part of any treatment, whether it is a drug, whether it is a biologic, whatever, initially it will always be like this. Yeah. But at that stage, we have to go through that to establish its longevity. If we are able to establish, it will settle. If it doesn't, it gets thrown by the wayside. Any treatment follows that.
Well, the one thing I encourage the audience, if you guys are doing these studies and contributing to the scientific literature and all of the panelists, is don't conclude your study at 6 months. Don't conclude your discussions, your talks at 6 months to a year. I want to hear you may not have done it for 5 years, but I want to hear if you've done it for 3 years, 2 years, 4 years. What did you do with those long-term protocols? What did you see in terms of long-term risk? What are the benefits long-term? How did you change your protocols? You know, you heard my talk about eyebrows. How did I evolve? How did you evolve those? I know this is all new and emerging, but I think those are good things to keep in mind for future sessions, HAIRCON 2021, 2022, et cetera. Any other questions from the audience? Right now, we've sort of covered all the major topics. Any questions to any of the speakers?
I would like to add just one piece of information on the concentrations of PRP. We were debating whether 3x, 2x, 5x, 8x, what is better. One of the drawbacks is when the concentration increases beyond 3 or 3.5 times, the PRP effect is reversed. Is reversed because you also concentrate the hair growth inhibiting factors along with the concentration in the PRP. So the ideal range falls between 3 or 3.5 times. A PRP preparation that is concentrated 5x or 8x does not give clinical results. The results are reversed.
The question is, how many people activate it? First of all, how many people activate your PRP? Raise your hand. When those people that activate, how many people activate chemically? Calcium gluconate, thrombin. How many people activate it mechanically? Microneedle stimulation? Very few. So a little bit. How many do both? No. I do mechanical. How many do PRP with? Okay. Raise your hands that people do PRP. Raise it again. So a lot of people don't activate. Is that right, or are you just too scared? And those people that do PRP, raise your hand. Keep your hands up. How many do it with surgery? Most do it. How many people do it standalone only? Interesting. So most people do it. Okay. So most people do it with surgery. Is interesting. And as a standalone, this is what I've noticed in my clinical practice. I do a lot more with surgery. I do every surgery I do it with it, and standalone, I just haven't gotten maybe the right protocol to get consistency.
By standalone, do you mean without any other medication or without surgery?
Oh, I'm sorry, without surgery.
No, I think that you might ask them to
So how many people do it when thank you for that clarification. How many people do PRP without surgery? Raise your hands. Okay, so there's a lot more. So people are doing it with other medical therapies. And this is so difficult from a scientific standpoint because there's so much of this mix of minoxidil, and we've heard this, and I know that study was good, but there's so much difficulty. I think that's what Dr. Satur is trying to elicit as well. A lot of our financial biases, a lot of the nocebo effect, placebo effects are hard to tease out, but it's worth discussing. Dr. Singh?
Yeah, but seriously, we still see that PRP does help you. Whether you talk about it as a plasma holding solution, you talk about even as a monotherapy. Like, I'll tell you, one of my first clients, when I started PRP, was my own wife. So I have the whatever evidence level you can say that I have that. So because of her second postpartum pregnancy, she lost about 60% of her hair, She had a hormone imbalance and she lost. We waited for quite some time and then we started on PRP, after 6 months. She recovered quite significantly, if I talk about, And not only she restored good density, but I've seen over a period of time, the length of hair shaft also increased. So I think that was very significant because she never used minoxidil, she never used finasteride, and because she was very aversive to using any lotion or anything on the scalp.
Yes.
So I just said, okay, let's do PRP because this is autologous, so don't worry on that. It's your own blood, so it will not harm you. So that was one of the things. And along with that, I started even nutrition therapy for her, though at a later date, but I'll just start her. But definitely helped her.
Good.
So
we're about a minute and a half left. Let's talk about some consensus comments. Does PRP work? Yes, no, maybe. I think it's a qualified yes. It's still, there's a lot of the biases that we all have. There's a lot of the studies are uncontrolled. The question is, does it last long? What is the standardized percentage in terms of the protocol of the 3x, 5x? What is the controlled volume? Do you activate it? Do you multimodality? It is, unfortunately, the science is still, in my opinion, not clean enough to give a definitive yes. So I think it's a qualified yes. Should we join the ISHRS? Not really. No, I'm just joking. Don't tell Victoria that. I'll be kicked out. Yes, you should. Do supplements work? I think it's a qualified yes, and the reason I qualify it is because there's just so much variable in terms of protocols. I mean, it's so easy to just say, oh yes, they work, but which ones? How much? Which ones are not as effective? Standalone, mixed, it's just difficult. Do stem cells work and fat stem cells work? We can sort of lump this together, and you heard all my concerns. It's, again, all the biases, all the protocol issues, but for me, it boils down to safety and longevity. And I just want to encourage those that are doing studies to think about those issues, especially besides safety, which, I mean, blindness is nothing to sneeze at. It's horrible. But we're really, all the discussions we've had have been too short. Our discussion, 6 months, 12 months, 8 months, it's not sufficient in my opinion, especially when you ramp up the morbidity. You really have to think about these issues. So we're on time. Thank you. Enjoy the coffee break. We're on time. And come back promptly. You'll listen to the bell. Thank you.
Thank you, Dr. Lam.